Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Tom, good to see you once again.
Parker, happy Thursday.
Happy
feels
Thursday.
Like the first
twice
time
in 1 week.
Yeah, and it's our usual recording time, so feels good.
Oh, you're saying feels like the first time we've done as we were supposed to on a Thursday record an episode.
It's definitely been a few weeks, part because of July 4th and some other stuff.
Yeah,
so.
I did a little bit of traveling and 4th of July. We've been recording sporadically, Mondays, Fridays. I was rewatching one of our older episodes, and my fiance said, "Hey, you look a little tired there," and I was like, "What?" And I rewound to the beginning of the episode, and at the beginning of the episode, we said, "Oh, it's Friday. It's not the typical day," so that's my excuse.
Although
I won't say which episode.
You should look less tired on Friday, maybe, or
you think so?
Getting that weekend energy up. I don't know.
There you go. Well, we'll see if we can. It's Friday Eve, so we still have some energy left in the tank. We can definitely do this today. So welcome back to the Sit and Stay podcast, brought to you by RipsyTech. Today we wanted to talk about a very important topic that specifically pertains to a lot of psychiatrists, which is the idea of performing therapy for your patients as a psychiatrist. So, Tom, as the psychiatrist in the room, I wanted to ask you, what are the benefits of a psychiatrist choosing to perform therapy sessions with their patients alongside their medication management?
Yeah, no, this is a exciting topic and something everyone who's a physician or goes to medical school or is relevant for nurse practitioners as well. And just for a little context, right? I think in general, when you're going through medical school, you're exposed to lots of different career choices. And then the one thing that tends to stand out about psychiatry is, hey, you actually get to spend more time with your patients. Now, in medical school, you actually get to spend a lot of time with all your patients, but you kind of realize that, hey, if I'm a pediatrician, I'm going to be cranking through 5 patients an hour. Or if I'm a cardiologist, likewise, you're going to be just cranking through lots of patients. And one thing you learn pretty quickly is that's not great for patient care. And a lot of people tend to want more time with their doctor. So one thing that definitely appeals to a lot of people in medicine is, hey, in psychiatry, you get time to know your patients and you can actually spend an hour with them every week if you're doing a psychotherapy process. So I really believe, and we have some data to support this, that one of the main reasons people choose psychiatry is actually envisioning doing psychotherapy and spending a lot of time with their patients. And I think that no one in medical school is thinking, I'm going to sit there and just write prescriptions my whole life as a psychiatrist. We're drawn to it because of this intellectual stimulation of being a therapist and also wanting to have more time with our patients. So that piece being said, if you're thinking about the benefits of doing therapy with your patients yourself, is one, it's hopefully what you trained for this field to do. It's what drew you into this field, and that's going to lead to career happiness. There's definitely a benefit that if you're doing the psychotherapy and the medication piece, you don't have to spend time trying to coordinate care with an outside therapist. There's the other benefit that if you know a patient really needs psychotherapy, but you're only prescribing practice, sometimes we still feel that pressure. We used to say to pull out the prescription pad. Now it would be to move down to the E-prescribing section of Ripsy or whatever your EHR is. But when you're not in a position to offer therapy, sometimes, and we know this from data also, people will jump to medications when it's not the gold standard or best treatment. And I know that I always think about, if I was treating my own kid or my own family member, would I want to be there writing a prescription for a medicine when I know what they need is, half a year of weekly psychotherapy? And the answer is no. If you're going to be real about, we want to offer the best evidence-based practices for almost everything in psychiatry or mental health treatment, therapy treatment is better than medication. So if you put yourself where your only tool is medications, you may not be able to get the best care to your patients. And the reason I say that is because it is hard to find therapists as well. So even if you want to get your patients connected with therapy, and we can talk more about how the system's been designed, and it's not something, not trying to pass judgment or say if you're just in a prescribing only practice, you're some sort of evil or bad human. And there's just limitations that have happened in our healthcare system, specifically with mental health, that it is nice if you're the therapist and doing the medication yourself, or if you work in a group that has psychiatrists and therapists as well. It all comes down to, at least for me, trying to make sure we get the best care for your patients. And so if I'm a psychiatrist, I want to be able to use all the tools I'm trained in, and that's therapy and medication and some other things as well. So that's my soliloquy about psychotherapy as a prescriber. Yeah.
Well, so I imagine as a prescriber, that's something that you can only do as a doctor, but a therapist, there are, not all people who perform therapy have a medical degree. So I imagine there is some kind of financial implication that comes from performing therapy as a psychiatrist. Does it not earn you as much money to perform therapy as opposed to prescribing medication or just doing medication management in general?
Yeah, so here's where what you signed up to do from medical school versus running a profitable business, here's where there's conflict. And like you said, Parker, there's a lot of non-prescribers who are trained and licensed to do therapy. So LPCCs, licensed practical clinical counselors, marriage and family therapists, social workers, going up through psychologists. There's so many more trained mental health professionals that can do therapy. Is that what happens is if you decide to take insurance, the insurance reimbursement for psychiatrists for doing therapy tends to be lower than if you're using your skills to do what's called E&M, evaluation and management visits. Mm-hmm. I like to call it E&M because it's not just writing prescriptions. It's using the knowledge you've gained from medical school and talking about other aspects that you've learned throughout your training. And and I can give some specific examples here as well. And you can understand why insurance companies, there's such a shortage of psychiatrists and especially child psychiatrists, if you're in that field, that they'd rather incentivize you to be doing the E&M visits. And there's many other mental health clinicians that can do the therapy. So they'd rather prevent doctors from doing this. And if you go to work for Kaiser, other big medical groups, as a psychiatrist, it is very likely you're being hired to do evaluations and prescribe medicine, and they're not going to let you perform psychotherapy if you're working for a group. But we can talk about some solutions here, but just to be specific on the financial implications, if you do, in general, there are some people who crank through psychiatric visits and maybe do 3 or 4 an hour. I question if you can do good care that way. But if we're looking at it in general as you can do 2 medication visits in an hour, or you can do 1 therapy visit in 45 or 50 minutes, but not including sort of the note writing piece. For doing in very general terms, if we look at the most common bill codes, 99214, so 99214 plus 90833, the 90833 is 16 to 37 minutes of psychotherapy. So if you spend 25 minutes with your patients, you bill the E&M on complexity, and then you've done at least 16 minutes of supportive psychotherapy in the medication visit, that's going to get you that bill code. If you go above the 37 minutes and do 38 to 52 minutes of therapy, so if you do a 45-minute session, the difference between several insurers we take, so for that extra 15 minutes of time, for one insurer, you get an extra $20. For another, you get an extra $50. For another, you get an extra $40. Which on some level may sound reasonable, but we're talking about being paid in the hundreds of dollars for that 30 minutes. So in terms of lost revenue, if you're doing one 45-minute therapy session in an hour versus 2 medication evaluation sessions in an hour, you're sacrificing $200 to $300 pretty easily in terms of what you're earning in that hour. Now, asterisk, you could do 3 45-minute visits in 2 hours, or you could do 3 40-minute visits. So theoretically, you could do 3 40-minute visits in 2 hours and 4 medication visits. Then the lost revenue is not as big. I think when you're billing the E&M codes and complexity and the psychotherapy different, the session time, you have to leave a few minutes. This is a nuance for insurance billing to show that you've thought about the complexity of the case.
Right.
So it's hard to put 40 minutes. I shouldn't say hard. Like, you can definitely figure out the complexity and the billing piece within a couple of minutes, but for other insurance reasons, it's hard to do just a 40-minute session. And anyone who does psychotherapy even knows that sometimes it's hard to limit therapy sessions to 45 minutes. You have to really push yourself to, let your patients know you do 45-minute therapy and be sure you sort of start wrapping up with the 5 minutes to go. But yeah, now I have more to say on this, but let me pause here for your thoughts on that information.
Yeah, I was thinking about how the choice to perform therapy as a psychiatrist seems very much like a personal decision based on, how you want to practice as a mental health provider, in that when it comes to having the freedom to make that decision, it sounds like it's more common in a private practice where you can make that choice for yourself versus a group practice where the group practice might have administrative people, and to pay those people, their wage, it does rely on a certain number of, or a certain amount of revenue being generated by the providers who are, I guess, the money makers of the business. So I was kind of wondering, if somebody's doing that in private practice. I guess you already kind of touched on this. Maybe this might be more of a comment than a question, but it does sound like it really kind of comes down to like personal preference, personal virtues, or I'm not sure if I'm using the right word, but choosing to perform if you find it to be satisfactory or more beneficial to the care that the patient is going to be provided, then, by all means, go for it. It does sound like there is a little bit of a financial sacrifice that you have to make in order to make that decision.
Yeah, no, well, and you brought up a good point, Parker, and this is definitely a driving factor and a reason for why there are so many psychiatrists that decide to do private practice, because the one way to not let it really affect your financial goals is to, set up private practice and set your therapy reimbursement the same sort of as your the E&M reimbursement, and not deal with insurance companies that don't value your time as a therapist with your patient. So that is a huge factor in why a lot of psychiatrists want to do therapy. They see what insurance companies reimburse and don't want to deal with it. So you can solve the issue of not being able to perform therapy by doing a cash practice. And again, so then it's the other balance of, well, then you're serving people who can only pay for that. And there's other pros and cons on all these topics. Mm-hmm. I would say on some level, I'd say on the group level, it's big contracts and other entities that have negotiated rates like this. And I'll say, when I was running our large group practice with all levels of practitioners, we fought very hard to get reasonable reimbursement for therapy. And we had several insurers that paid very, very reasonably for psychotherapy services. And the way we modeled our pay structure was, we're able to set a salary that if you come work for us as a psychiatrist, here's what your minimum salary is going to be, regardless of if you only see patients for psychotherapy. If you see some extra patients in extra 30-minute visits versus the 45, then you're going to get some extra pay for doing that because the company makes more money. And it's, since the pay depends on bill codes and types of visits, doing this sort of bonus system based on RVUs you generate, which you generate more RVUs for a 30-minute E&M, 2 30-minute E&M visits in an hour versus a 45-minute therapy. So that's how we sort of dealt with letting our psychiatrists do psychotherapy, knowing that their salary would still be a good salary, but would be a little bit lower. And I do think that's how we recruited 30 plus psychiatrists to join the group, right? Because we could say, hey, here's a place where you don't just have to sit there and write prescriptions for your whole job. So that piece, plus the fact that we had a lot of therapists and psychologists as well, and it's a multidisciplinary team approach, made it appealing. So there are some strategies, though they require a lot of effort to try to deal with these implications. But it is hard, now that I'm back in a smaller group at the nonprofit where we have a lot of goals for what we want to do for the community and the patients. You really, it is hard to overlook the financial implications of the amount of money you're giving up when you're doing psychotherapy. So we try to strike a balance between, having the right number. Our schedules are a mix of intakes, therapy sessions, and then E&M, 30-minute E&M follow-ups. And it's okay if you have if 10 of your 40 hours in a work week are therapy patients, that tends to be an okay sacrifice financially.
Are there any kind of specific, I know we've touched on this quite a bit, and I just want to make sure we covered everything. Are there any kind of specific differences that one should know about when it comes to the billing and the insurance reimbursement for doing therapy as a psychiatrist versus your regular E&M visit?
Yeah, so you're definitely so psychiatrists can actually bill these therapy-only codes. It's not best practice for you to do that. A lot of psychiatrists are under the impression that if you're only doing therapy and not prescribing, that you're not allowed to bill an E&M code, and that is not true. And that's another reason why I like to call them E&M codes, that stands for evaluation and management. It doesn't stand for prescribing medication. So I always try to counsel psychiatrists or nurse practitioners that you should always, whether or not you're prescribing, you're using your skills you learned in medical school and residency and fellowship when you're treating your patient, and that's what you can integrate in and bill for E&M. I would say that it's a good time to mention the other sort of flaw in the reimbursement system is that insurance companies tend to reimburse that initial intake lower than any future appointments, so even lower than a 30-minute medication follow-up. And there are lots of different ways to bill that intake session, and we should do a podcast, Parker, on billing strategies by session type. The medical billing system, sometimes there could be 5 different ways to bill a session that are all legal and totally appropriate. And so learning specifically for your practice which of those gets you the best financial reimbursement starts to be part of an art form. And we have some tools in Ripsy that you can put guardrails in to warn people if, hey, you're billing this, but maybe consider billing it this way to earn more revenue. So I'll just leave it there because it's too much for this episode, but it'd be fun to do an episode with what are the 5 different ways to bill an intake or the 3 different ways to bill a follow-up, or so that will be a good session. But
yeah, sounds good. I've got it written down right here. So then I would like to flip the perspective to the side of the patient. I was wondering if I'm a patient who is seeing a psychiatrist for evaluation and management, but now I want to see them for a therapy session, should I expect to pay a different amount or be billed a higher amount for that therapy session than if I went and saw an LMFT or a LPCC or LCSW?
Yeah, so if you're going to a psychiatrist for therapy, and especially if you're paying cash or out of pocket, the rates for therapy with a psychiatrist are going to be the highest. That's not totally true, but in very general terms, in the San Francisco Bay Area, the most you'd pay in the cash practice for therapy with master's levels, probably $150 to $200 an hour. For a psychologist, it could be $300 to $400 an hour. But there are some psychiatrists that are $500 plus. Now that usually does include the E&M service as well, but in general, the time of the psychiatrist is going to be the highest paid. And so there is an interesting phenomena, or I shouldn't even say phenomena, but there are a lot of patients that don't even realize that psychiatrists do psychotherapy. So there's, and this happens to us we try to sort of advertise the psychiatrists in our group do therapy as well. Mm-hmm. Mm-hmm. But and this happened this week when I was meeting with a new patient, they're surprised to hear, you actually can do the therapy with us or with our child. And it's just become so ingrained in our healthcare system that psychiatrists just write prescriptions and you need to find someone else to do the therapy. It's always a little bit of a sad feeling, but that is the reality on how the healthcare system has worked around costs and the roles that different providers are pushed into. So lots of times for our patients that the copay is the same, whether they see you or a therapist. If they have a $20 copay, then they're very excited that they can stay with the psychiatrist for the therapy component as well. So that's maybe a nice surprise on the other side.
How about actually in practice, how are patients typically responding to having their psychiatrist also being their therapist? Does that have any impact on retention or satisfaction? Is it is it different for people opening up maybe? Is it easier? Is it more difficult? I'm curious.
That's a really good question. And there has actually been a fair amount of research on, quote, who's the best therapist. And the reality is that just having the MD after your name does not make you necessarily a better therapist than a master's level provider or a psychologist. The data has consistently found that your training has less to do with your skill as a therapist versus just your ability to build rapport with someone after a few sessions. So, which is actually good news, because it means if you're building a group practice or you're in a situation where you can't do the therapy, it doesn't mean that your patients necessarily suffer by having a different level medical professional as their therapist. Yeah, and it's also, I think the saddest thing for me is when people finish their training, and usually you complete a lot of therapy training when you're done with your fellowship for medicine. But then if you go to do a prescribing only job for a few years, a lot of psychiatrists get scared that they don't know how to do therapy anymore, or feel like they wouldn't be a good therapist, and try to support and push people that, you can do it and you can read books and you just need to get your practice back. But I'm always sad when I hear psychiatrists are scared to do therapy because they've been out of the game for a while or something like that. But definitely your degree and training by itself tends to not have an impact on patient outcomes as a therapist.
Well, that is really good to hear. I was thinking about whether it's not necessarily a dual relationship, because that is kind of like a specific term that is reserved for something very specific. Though in this case, thinking of like, this is my therapist and my psychiatrist, I was kind of wondering if there was maybe any impact there. But it sounds like, kind of as you put it, it's really not that kind of a black and white thing. It really does seem to be more of like a person-to-person rapport kind of thing. It's not this like line in the sand that's like therapist over here, psychiatrist over here. It's really just, the one person who's providing your mental health care.
Right. And I would say, the one thing about that I feel like the field of mental health treatment is getting better at, but there for a long time, and this went with sort of the stigma around mental health also somewhat, that it was sort of what goes on behind the secret closed door of the therapist office needs to stay secret. And I think that we have more of a responsibility to our patients that we're embarking on with therapy to say, here's the type of therapy we're doing. Here's how many sessions it's going to be. Here's the specific stuff we're going to work in therapy. Because we do see lots of times where people come in and are doing very poorly, and then you're surprised to hear they've been in therapy for 4 years, and you're like, well, what's going on? You're sort of wondering what's going on in the therapy, because we know that there are specific types of therapies, and you need to pick the right therapy for your patient, and you should be tracking and seeing improvement. It's another thing we're trying to make easier in Ripsy, as you know, to like quickly see how your patients are doing. And it shouldn't just be a come in and talk for 45 minutes with a friend. Like, this is a professional relationship. You have an obligation to engage in that therapeutic process and help your patients get better. So that is for anyone who does therapy. I'd like to see that shift continue, that we're being more open about what's happening in therapy. It's not a secret. Here's the goals we set, etc.
Well said. Anything else that you'd like to say before I move on to the mental health business moment?
Yeah, no, I think we did a good job with some specifics and some generalities. And I would urge people, even if you're taking a job where they want you to just do medication visits, to like, hey, fight for, what, I'd like to take 4 patients in therapy. I'd like a half day a week of therapy. Any person offering you a contract or job for your skills, would probably agree to that. I think as a profession, we need to be a little more forceful about that. And so just something I'd urge people to ask their employer for if they want to do psychotherapy with their patients.
Awesome. So, well, I guess with all of that being said, let's move forward to the mental health business moment. What are we had kind of like a happy ending to a long weeks long mental health business moment saga in our last episode. I'm wondering what you have for us this week.
Yeah. Excuse me. It's interesting to think about, right? What's on my mind is we're sending out our June invoices to our patients. And, this is something we're really working hard on automating and making easy as possible to get reimbursement. And I think we have, I think it's sort of just a general frustration with credit card fees. So it's another one of these pros and cons situation, though, that, and in our practice, we're actually switching to requiring a credit card on file and being able to just automatically run payments. That being said, we have patients who are, it's just frustrating that it's not as easy to accept payments for lower fees as it is to accept credit cards. And it eats into, right, you're giving up 3%-ish of every payment you get from the patients to those credit card fees. And that's what's been on my mind. It's sort of a general issue. We have, until, there's Zelle, which doesn't charge any fees right now. Asterisk, I'm sure they will at some point. But it would be nice if there was easier mechanisms for payment structures that didn't take a fee, without having to go back to people writing checks or things like that. So,
right. Yeah, understandable. And every time I use an online system that, it's credit card, 3% fee, or, like an electronic check. I try to go for the electronic check whenever it's available, but it's a slightly bigger hassle to deal with, just getting all of that put in.
Yeah,
very understandable. Well, I think now would be a great time for us to wrap up the episode. Tom, it's been great seeing you. Twice this week for podcast episodes. So go ahead and what do I usually say? Oh yeah, that's right. Go ahead and send us any questions you have to sitandstay@RipsyTech.com. We will answer them in an upcoming Q&A episode. And if you're interested in being a guest on the podcast, go ahead and send us an email there as well. As I mentioned in the last week's episode, we have a few guest episodes coming up that we're recording in the next few weeks that we're very excited about. So stay tuned for more information on those. And if you are listening on YouTube, be sure to like and subscribe. And if you're listening on whatever podcast platform, be sure to follow us. It helps us out, and we appreciate it greatly.
Awesome. Thanks, Parker.
All right. See you next time, Tom. Bye.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at RipsyTech.com.